Sir, can you see?
Yes, we are able to see. We can see that Rudransa has started, but now again it has gone.
Oh, there's some problem with the.
What you can do is you can send the PPT to my mail. And when your turn comes, and I can share the screen. Or you can send it to Neha also. She can also do that.
Yes, ma'am.
Neha, if you can share your email ID,
Yes, sir, I'll do that.
the chat box you can share. Because anyway, Rinki is going to speak last, so we can wait for a few more minutes and then start the discussion. And we are live on the YouTube already. જગજીભાઈ તમારે ત્યાં આવ્યા છે કોઈ AES ના કેસીસ?
ચાંદીપુરા વાયરસ ના?
હા, any I mean acute encephalitis.
નહીં, એક પણ નથી, કારણ કે પંચમહાલમાં ને એ તરફ વધારે છે. કાલે જ હિતેશભાઈ મેં
Most
પૂછ્યું.
of them end up with government institute.
Yeah, and they are sent directly to SST hospital.
Kiranbhai, good morning.
Good morning. Nice symposium. Chalo.
Thanks to your suggestion.
Okay, chalo.
We'll wait for a couple of minutes and then we'll start. Let others join.
Yes.
Dr. Neha, I have shared my PPT with you. Is it?
Yes, ma'am, I got on WhatsApp. I'll do that.
That's fine, no?
Yes.
Okay.
So Neha, when you are ready, no, we will start. First, Dr. Parag is going to speak, but once you are ready with both the PPT, you can start. So later on, we don't waste time.
Sir, I just try once Rinki ma'am's PPT to open and just share.
Yes.
1 minute, sir. Sir, is it visible?
Yes, it is visible. Yeah, just try to put it on slide. So yes, it's moving also. So this is fine. So when Dr. Rinki's turn comes, no, you can present her presentation and second.
Yes.
Thank you so much, Dr. Neha.
Yes, ma'am.
So good morning, friends. Welcome back to Saturday Club of Baroda morning meeting. And this time, actually, this Saturday, we had planned another talk. This was by Dr. Rajiv Bhatt on oncology. But then there was a demand and Dr. Kiran Shah suggested that we should discuss Chandipura virus, which is making so much headlines, for last month or so. So at a very short notice, I requested all these three speakers to have a symposium on the subject so that we can have perspective from all practical aspects of Chandipura virus infection. So to start with, we have Dr. Parag Chawda with us. He is MD, CMCL, Famer Fellow. He has done advanced course in medical education. He is Associate Professor of Community Medicine at GMERS Medical College, Vadodara. He has authored several publications, 17 PubMed publications, 5 book chapters and 1 book, and recognized as Fellow of Indian Association of PSM, that is FIPCM. He's Eminent Medical Teacher Award by MEU India Group in 2022. And he has several organizational positions also to his credit. So first we'll have Dr. Parag Chawda, who will talk about the epidemiology of Chandipura virus infection, practical things about sandfly, because there are a lot of parents who get worried even with 1 day's fever. They start asking questions about this virus, how does it spread and all that. So I think Dr. Parag will be telling us about the epidemiology of the disease and the vectors habitat also. So over to Dr. Parag, and thank you for joining Saturday Club. Thank you.
Thank you, Satish sir. Thank you for making this part of this Saturday Club series. At the start, I would like to start with a sense of gratitude to all my senior teachers, including Bakshi sir, who is here, and other members of the community medicine fraternity who have enriched my understanding of Chandipura and AES, that is the topic. Today I'll focus more on the environment and vector part of the disease, and I assume that the agent part and the host related factors are going to be covered up by the rest of the 2 eminent speakers. So this particular incidence has brought a lot of attention towards sandfly, otherwise which we had almost forgotten within the textbooks of community medicine in the chapter on entomology. In fact, we community medicine people and largely people in public health also did not pay much attention to sandflies because there were no such diseases as such which were prevalent, which are transmitted by sandfly, except some other diseases which are in other parts of India, especially in the northern parts of India. Where, so a lot of our understanding of sandfly still comes from there, because there sandflies are there and it causes disease transmission as well. So as we understand, the sandfly, the adult, if we look at the sandfly adult, the sandfly size is almost half of that of the mosquito. It's light brown in color. It's a hairy insect, and that's why it's difficult to be seen by naked eye. Now, one of the important things that differentiates sandflies from the other insects, such as mosquitoes, is that sandfly is something which you would find very closely in association with animals, with cattle, right? So we usually say that you will find adult sandflies in the cracks and crevices in the kacha houses. So back in the days, say for example, when Bakshi sir investigated the cases of Chandipura somewhere around 2009-10, so those were the days when, say in the rural areas, we had a lot of kacha houses where the walls are plastered by mud, and hence there are chances that a lot of cracks would be there, and then the animals are also there. So there, the sandflies prefer to stay, the adult ones prefer to stay there, and that's how. So during the daytime, the adults stay there, and during the night time they come out and they can bite. The females usually bite, and that's how we assume that it transmits the diseases from one person to the other person. So usually we understand it's from the reservoir to the animals, and we understand that human beings are dead host. So in that sense, that needs to be looked at. Another important aspect is that as the development is happening in Gujarat, so back, say, if I remember 10 years back, then we used to see a lot of kacha houses. Now, many of those kacha houses are being converted into pakka or semi-pakka houses. So you do not see those, you may not see those classic mud plastered walls, but the animals are still there. So they have not gone away. So I wish to see this from the socio-epidemiology point of view also. In rural areas where cattle are kept, they are considered as part of the family. So ideally, when we say that the cattle should be kept, even if you are keeping cattle, the cattle should be kept away from houses. what we need to understand, there are two different perspectives. People see them as part of the families, and hence they are kept very close to their households. We see that from public health perspective, for us to prevent any zoonotic diseases affecting human beings, they should be kept little away. Still, we say that if people are keeping animals, the animal cattle shed should be away from the houses, so that the animal human and the vector human contact can be minimized. So that's one. The sandfly prefers to bite at night. And another important thing related to sandfly is that sandflies do not fly by choice. So unlike mosquitoes, which fly by choice, sandflies do not bite by choice, do not fly by choice. So they hop from one place to the other. So you cannot really go very far when that particular vector is hopping in nature. That transport is through hopping. And hence, the spread of, let's say, from the breeding place, the spread of sandfly is roughly around 50 meters from the breeding place. This is similar to Aedes, where, say, for example, the flying range even for the Aedes is somewhere around 100 to 150 meters. So it's very close. And hence, probably partly explains the sporadic nature of the illness, that if the vector itself does not get transported by itself too far. So that's also important thing for us to understand. Now, if we go with the hypothesis that sandfly is the causative vector for this particular disease, and then probably what we gather in terms of prevention is that since it cannot fly, it's likely to bite in the lower parts of the body. It's likely to affect you if you are sleeping on the fields, especially in the areas surrounded by cattle and animal. By that hypothesis, we are also saying that it's purely going by this hypothesis is unlikely to be seen in urban areas. For example, very commonly when we teach sandfly to undergraduate students, I commonly ask them, if I were to send you to catch sandfly in Baroda city, where would you go? And the answer expected is that the only places in Baroda city where you still see cattle is the places where there is animal husbandry. લોકો ઢોર રાખે, ગાય ભેંસ રાખતા હોય, ત્યાં તમને sandfly મળે. એના સિવાય અર્બન એરિયામાં sandfly ક્યાંક મારા કે તમારા ઘરમાં મળવી બહુ જ મુશ્કેલ છે. It's almost the possibility is close to nil. So that's one part of the, say for example, the vector and the environmental related factors. Now, apart from that, another important thing is that we are not really sure as to what's the causative vector. So that's also a possibility. So many of my colleagues from different parts of Gujarat who have been part of the investigative teams are also keeping the possibility open that it could be some other vector as well. So mosquitoes as a vector, especially Aedes, is still a possibility. We are really not sure. And since the number of cases are very limited, the kind of questioning that you can do, since it is causing a lot of deaths, is also limited. And sometimes information might not be completely available in public domain. So that restricts, in a sense, our understanding about the topic. So can we say that we know everything about, say, for example, the environmental factors related to AES cases that we are seeing currently? Probably not a resounding yes. So with that limitation, we are sharing whatever we understand. So the preference is that we still call it as cases of AES rather than terming it to any particular agent in particular. So the parting thoughts are that this particular incident since last 1 or 2 months has brought once again in focus the One Health approach, right, where we also take parallel care of the animal health part of the entire global health as an issue. And behavior change, so for example, with the climate change, a lot of things are happening in parallel. That also makes it difficult for us to conclude something. So people going more into nature. So for example, there are theories that the virus might be there in the urine, in the cow dung, or in the cattle dung. The virus might be there in the milk. But all of those are theories, so we really don't know. So the preventive advice is sometimes you also see that overall hygiene, that's what we usually see in outbreaks, that if you can keep the overall hygiene high, if you can take care of the sanitation measures, sometime it might help. So even before coming to conclusions as to what's the causative agent and how it gets transmitted, the overall sanitation measures might help. And that's how really public health works in practice, that when you investigate and start controlling, you many times are not sure of the agent, the source, the reservoir, and the transmission mechanism. So that's what is my basic understanding around the current incidents. Thank you.
Sir, you are muted.
Thank you, Dr. Parag. That was very comprehensive, epidemiological and preventive aspect of the AES cases that we are seeing. And of course, there are many questions which can be discussed later. Once all the three speakers have finished, we will have some question answer session. So Dr. Parag, stay back with us. Thank you for joining us. Now we have Dr. Neha Patel Nakshiwala with us. It's a pleasure to introduce her. Saturday Club of Baroda is known to give opportunities to young clinicians to share their experiences and knowledge. So this time I took this opportunity to invite her. She is a consultant infectious disease expert. She sees both adults and pediatric patients, and she has done her DNB pediatrics from Kokilaben Dhirubhai Ambani Hospital, Mumbai. And she did her fellowship in infectious disease at MUHS, that is Maharashtra University, Lilavati Hospital, Mumbai. And she also has additional work experience of ID in BMT at KDH, Mumbai, ID in solid organ transplant from HN Reliance Hospital, Mumbai. And most important, she has also had experience from clinical tropical medicine at CMC Vellore. So with this brief introduction, and of course, she has several publications to her credit. And I have shared all the three speakers' CV in our group because they are lengthy CV and will take more time. So now I request Dr. Neha to tell us about the clinical aspects of this Chandipura virus infection. Over to you, Dr. Neha.
Thank you, sir. Thank you for the opportunity. Good morning, everyone. I'll just share my PPT. Is it visible, sir?
Yes.
Chandipura virus is a member of genus Vesiculovirus, family of Rhabdoviridae, and envelops single-stranded RNA virus with approximate genome length of 11 kilobase. Discovered first in 1965 during an acute febrile outbreak in Nagpur, Maharashtra. And from that, the name has come as Chandipura virus. First encephalitis outbreak in 2003 in young children, that was in 2003. There is electron microscopic image of the Chandipura virus. So Chandipura virus has 5 different proteins, N, P, M, G, and L. And P protein plays a vital role in virus life cycle. So here, yes. So 1965, there was one first outbreak. Then in 2003, 2004, Vadodara district of Gujarat had again outbreak with 70% case fatality rate. Then there was outbreak in Andhra Pradesh in 2005, 2006, when the case fatality rate was 54%. And the recent in 2024 large outbreak in 33 districts of Gujarat, Rajasthan, Madhya Pradesh, and Maharashtra as of now. This courtesy for these slides is to Bakshi sir. Thank you for sharing this particular slide. So these are the areas when where the rain is distributed, and you can see the cases, number of cases. More are in Panchmahal and Banaskantha, Sabarkantha areas of the Gujarat. And this is showing the animal density. The more is in this blue area. So epidemiology, Parag sir has already covered. I'll just briefly go through this. Human host, children under 15 years old are more susceptible. Animal hosts, as per the literature, cattle, goats, pigs, buffalo, sheep, camel, rodents, and even lizards. So these are xenodiagnosed in animal host, but there is no particular illness or clinical features in animal hosts. And vectors, yes, as we know, sandfly, phlebotomous sandfly, and mosquitoes and ticks, these are not confirmed because they are not xenodiagnosed. But at present, NCDC team who is working on the field, they are collecting mosquitoes and ticks to do further research. But as of now, we know sandfly as they are the vectors for Chandipura virus. And incubation period is 5 to 6 days. And extrinsic incubation period in sandfly is also 5 to 6 days. So sandfly life cycle, there are 4 stages: adult, egg, then larva, then pupa. And there are 4 stages of larva. And there is a transovarian infection. So transovarian, when that sandfly bites, that will transmit the virus to the host. And host characteristics and transmission. So Chandipura virus transmission is hematogenous route. And of the same group, rabies virus is also a same rhabdo family virus that travels retrograde manner from neuromuscular junction to the brain. But here the Chandipura virus is anterograde, and it has a rapid transmission, and it is very fatal, and it causes very severe cerebral edema. Age-dependent susceptibility, as we are seeing in many other neurotropic viruses also. Pediatric age group less than 15 years. There is no gender prediction, and host factor risk factors. So NCDC ongoing, they are doing case control studies, and they have observed broadly that low socio-economic status, malnutrition in children, and children playing in the fields who are more in contact with crops and staying with cattle and domestic pets. It is like practically living together, as Parag sir correctly said. So these are the factors they could observe in all the cases, suspected and confirmed cases of Chandipura virus. And there is this is the study done in mice. So cell-mediated immune response. The infected mice secreted significant amount of pro-inflammatory cytokines like TNF-alpha, MCP-1, and high amount of interferon, interleukin-1, interleukin-6 at 24 hours of post-infection. A reduction in significant amount of CD4, CD8, and CD19 positive cells at 72 hours post-infection. So might this makes mice immunocompromised during the infection. So this study is done in mice. We don't have human data. Clinical presentation, there is a spectrum from asymptomatic to febrile illness, then acute encephalitis syndrome, and even death. So prodromal phase lasts for 1 to 3 days prior, fever, myalgia, malaise, and headache. So very short duration of history of high-grade fever. And then that will go into encephalitic phase, where there will be persistent fever, decrease level of consciousness, seizures, abnormal movement, focal neurological deficits, etc. And depending on severity and immune responses, some may succumb and some recover through post-encephalitis sequelae, cognitive decline, paresis, involuntary movements, seizures, and some can have complete recovery. So case fatality rate, as we saw previously in previous outbreaks, the range is 40 to 76%. And this is the data of previous outbreaks where in Nagpur and Gujarat, Andhra Pradesh, so fever was consistently like 100% feature of this viral infection. And after that, there was altered sensorium, even vomiting, convulsion, 40 to 89%, and others. So this was the brief clinical presentation of Chandipura virus. Now the diagnosis part. So as of now, this is from Pune, NIV Pune, that they do single step PCR target. They target the P gene and other serological tests. So these are not commercially available. So these are done in Pune, NIV Pune, serum and CSF, IgM and IgG ELISA test. And this plaque reduction neutralization test, which is called as PRNT assay using live virus, this is the most reliable. And as of now, they are doing neutralizing antibody analysis with this test. So this is one data where it is showing timing of appearance of antibodies. So IgM and IgG. So if we see IgM is seen in from 0 to 4 days, and even at day 4, and IgG comes later. Presence of neutralizing antibodies in all domestic animals, that was also done from NIV Pune. So they saw that pig was the animal host in which they could see more of presence of neutralizing antibodies, and others animal hosts like goat, cattle, buffalo, sheep, dog. So this was a bit on diagnosis part. Now the treatment, as we know, there is no specific treatment available. Only supportive treatment is the key, and early care initiation is very valuable, and no vaccine available as of now. But there are studies and done again by NIV Pune. There are 2 vaccines they did study. One was inactivate virocell based vaccine. The study was in mice, and they noticed the neutralizing antibody titer. If it is more than 1:20, then mice survived. But we don't have data in humans. So this is a promising work, and this has a potential in future to taken forward. And another, again, the recombinant vaccine, which is G protein, and there is T cell response in that, and they have noticed 2 weeks after the vaccine there was IgG antibody titer. But this
Your
is also
slide is not moving. There is only one slide we are seeing. We are not seeing
yes,
any
yes, sir.
markers.
It was on this only, sir.
Okay, okay, fine.
Yes. So 2 weeks IgG, they noticed that antibody titer was there. So these are the 2 vaccines they have already studied. So it has a potential to taken forward in future. But as of now, we know there are no vaccines available. And one study hypothesized that nucleoside and non-nucleoside reverse transcriptase inhibitor drugs will be able to inhibit virus replication because of close structural similarity of the virus polymerase, which warrants further scientific research data. So as of now, we know the supportive treatment is the only key. Preventive measures, as we know that surveillance activities and the vector control methods in indoor residual spray, application and requirement of synthetic pyrethroids, personal protection for the field workers who are doing work on the field and gathering all the data, and the environmental management, because the sandfly, they stay in dark, dampened areas where the very humid environment. And another thing, this in this epidemiology part of it, that usually we see that sandfly can go up to 6 feet of height. But this time, the team who is working on the field, they notice they even got the sandfly from the roof. So now they are applying all this pyrethroids and malathion on the roofs also. So this is the one change is seen in the sandfly habitat. So this is the latest update on acute encephalitis syndrome, Chandipura outbreak up to 1st of August. So cumulative suspected cases 148. Gujarat has 137. Rajasthan has 6. Madhya Pradesh 4 and Maharashtra 1. Cumulative confirmed cases 51, and all are from Gujarat. Cumulative suspected deaths 58, from Gujarat 56, Rajasthan 2, Madhya Pradesh 1. Cumulative confirmed deaths 19, all from Gujarat. And cumulative number of districts affected, Gujarat 29, Rajasthan 3, Madhya Pradesh 4, Maharashtra 1. So this is the data up to 1st of August. So there are unanswered queries in this. So this is this disease, we don't know the natural history of disease transmission dynamics. there are many more research work we need. Then the pathogenesis, immunopathogenesis, whether there is a cell-mediated immune response as we saw in this mice study. And if that is the case, then the role of the molecule which will help in cytokine storms, as we were seeing in COVID-19. So these are the unanswered queries. And then the age distribution, we will come to know when after a few days, as the NCDC team is working on field and they are doing case control study. So after that data, we will be able to answer these queries. And then the reservoirs, as Parag sir already said, that animal and the non-human reservoirs, and vectors other than sandfly like mosquito or ticks, etc. And the diagnostics, which are not very easily available. So these are the unanswered queries, which we will be able to tell in future after we get the data and the field work. Thank you, sir. Thank you, everyone.
Thank you, Dr. Neha. Again, a very comprehensive overview of the clinical picture and some epidemiological aspects also. And you have rightly at the end raised some questions which are still not answered. So now we come to a very practical aspect of the symposium, and that is a talk by Dr. Rinki Shah. Let me introduce her. It's a pleasure to introduce Dr. Rinki. She did her MD Pediatrics in the year 2013, and currently she is an Associate Professor at Government Medical College, Vadodara. She has several national and international publications to her credit, and she has contributed as author in undergraduate textbook of pediatrics. She has been very active, as I have seen her for last decade or so. She is very active in various organizations like Indian Academy of Pediatrics, National Neonatology Forum, and even IMA also. So she is very active and she has won a lot of awards for her work in all these organizations. So it's a pleasure, Dr. Rinki, to have you with us. And thank you very much for joining us at a very short notice. I called her only on Thursday and she said yes to this. In fact, I must give credit to Dr. Om Prakash Sukla also. Who is head of the Department of Pediatrics, Government Medical College, SSG Hospital. Because we read in the newspapers, we see video clippings regarding various cases that they are handling. So now we'll have Dr. Rinki telling us about what are their experiences of managing these cases in their setup. So over to Dr. Rinki. Thank you.
Thank you so much, sir. And very good morning, all of you. I request Dr. Neha to just help me in slide sharing. Yeah.
Yes.
Is it visible to all?
Yes. Yes.
Yeah. Next slide, please. Yeah. So regarding the suspected Chandipuram virus illnesses, I would say that encephalitis, acute viral encephalitis cases rather than the Chandipuram itself. So all the cases we had received, they were presented to us with the similar complaints, like all the patients were admitted in SSG hospital in last 15 days. We had seen cases they are presenting with the high-grade fever of very short duration, like they're presenting with 1 or 2 days fever and vomiting, diarrhea. They all start simultaneously. The children they are presenting with the altered sensorium, generalized convulsions, and many a time we receive in the patients who are in the status epilepticus. Children, they are also presenting with the signs of the raised intracranial tension in the form of the decerebrate posturing and further leading to the coma for several hours. We have received the children with the encephalitis or encephalopathy both. And as Dr. Neha has rightly told that it is a very fatal disease and in which we have seen the child in our data, they are dying within 1 or 2 days of a hospitalization. Next slide, please. Yeah, next. Yeah. So if I talk about our SSG hospital data, in last 15 days, we have seen suspected viral encephalitis cases There are 33 patients in total, out of which the Chandipuram virus positive were 6. And in one patient of the CHPV positive had dengue positive also. And that child had bleeding, that child came with the bleeding. And one child in which the JE was indeterminate actually, and one patient among these patients, they had positive of cholera, and like 21 patients they were negative, and still we are having 4 patients who are reports awaited. And if we see the death rates, so we have seen 18 patients who died so far because of this encephalitis syndrome. And these all patients, they were critical, like they died within 1 or 2 days itself. And 7 patients we had discharged so far. 2 patients, they are still in PICU, who are critical, and 6 patients, they are shifted to the ward. Out of the 6 patients, 5 patients were on ventilator. So we could extubate this child, and we could send these patients to the wards. Next slide, please. So among 18 what is our observation that all the 18 patients who died, they were very critical, and their presentation was like out of this 18 patients, all the patients who had disseminated intravascular coagulation, altered coagulation profile, including altered PT-INR, PTT. 11 patients had hepatic dysfunctions in the form of the raised liver enzymes. 18 patients had altered renal dysfunctions, in which urea, creatinine, and imbalance between the sodium potassium was also observed. 8 children who died out of 18 had malnutrition as a comorbidity, and 1 child has a moderate malnutrition. If I look into the immunization data of these children who died, only 6 children had complete immunization till age. Rest 10 children, they did not complete immunization, and 2 patients were whose immunization status we did not know. So I would say that this partial immunization is also we need to look into the matter, the number of the cases which are more. Next slide, please. So all the children who are presenting with this clinical features, we investigated in the form of sending the hemogram, renal function, liver function test, coagulation profile. We are collecting CSF as soon as the patient is coming. If TUDICO, we are having in-house TUDICO facility, so we are doing that TUDICO also, and we are having Dr. Chintan with us. So Dr. Chintan is helping us in making this reports available of patients who are having some cardiac involvement. Chest X-ray we are doing, and all the inflammatory markers, including the CRP. So our observation for all these patients were like in hemogram, if I'll say that these children, they have hemoglobin between 8 to 9 most of the time. So they are having the moderate to mild anemias. RFT in almost all the patients of suspected encephalitis, they were deranged. LFT, as I already told that it was many of the time it was deranged. And coagulation profile was also CSF in most of the patients, they were normal. CSF reports, they were normal. And CRP was significantly raised in many of the patients. Chest X-ray findings that was not significant, or it was inconclusive mostly. Next slide, please. So as soon as the patients, they are coming to us with these complaints like fever, altered consciousness, status epilepticus. So our primary goal for the management is to stabilize the child, to identify the diagnosis, because we don't know which illness it is. Actually, it is a viral illness, or it can be because of the malaria, it can be because of the dengue. So we need to put the proper diagnosis. We have to rule out the other conditions also, and supportive management we are giving. So as soon as the child comes to us, so we admit the child in the pediatric ICU. We manage the airway, breathing and circulation by just seeing the oxygen saturation, and provide the oxygen therapy. Those children who require the ventilations, on the basis of the clinical judgment, we decide the child to put on the mechanical ventilation. So we put the child on the mechanical ventilations. And fluid and electrolyte, what my observation is that many children who are coming with this kind of the symptoms, they are having dehydration and they are having the altered renal functions, dyselectrolytemia also. So there is marked fluid electrolyte imbalance is observed, as well as they are coming with the refractory shock. So as we are treating them as a first, we are treating as a hypovolemic shock. We are saying that if the child, the pulses are thready, tachycardia is there, low volume pulses. So we treat them with the boluses. If it is not responding to the fluid, then we starts with the inodrop as early as possible. And we step up the inodrops till we get the maximum results. In many cases, the shock, it is like refractory. So in that cases, we need to give an even hydrocort we are giving to the patients. And of course, management of the hyperpyrexia by giving the paracetamol. So around the clock management of the fever, we are also doing. As Dr. Neha rightly told that no specific drug available because we don't know that which virus it is actually. So it is we start the drug empirically only. So as soon as the suspected cases comes, we starts with the acyclovir, we starts with the artesunate also, and depending on when the reports come like PSMP is negative, then we stop the other drug also, and we are continuing with the acyclovir as an antiviral drug. Many patients we are observing with the raised intracranial pressure by seeing the clinical findings like deep cerebrate posturing and anisocoria. And they are presenting with the papilledema also, I mean, on the fundus examination. So we assume that these children, they are having the raised intracranial pressure, and we do the head elevation slightly by 15 to 30 degree if possible. And we starts with the mannitol, 5 ml per kg. Stat dose and followed by 2 ml per kg for at least for 2 to 3 days, and 3% NaCl also if at all required if it doesn't respond to the mannitol, because in my observation I've seen that the children, they are having the cerebral edema and these raised ICT features which they do not respond to even mannitol, so we need to give the 3% NaCl also. Next slide please. Patients, they are coming with the seizures, they are coming with the status many a time. So we need to give the control the seizures. We are giving the diazepam group of the drug, midazolam or diazepam itself, 0.3 to 0.5 mg per kg IV for the seizure control. And meanwhile, we are monitoring the respiration. If it is not controlled, then we give the phenytoin many a time. In most of the patients, we need to start with the phenytoin only. So we are giving phenytoin in the loading dose and keeping the phenytoin in the maintenance also. So once the child becomes a seizure free, then again we start with the feed, because the nutrition is also important aspect. Next, please. So if the child is coming with the DIC and active bleeding, so we give vitamin K, we give FFP, we give PEG cell volume and platelet concentrate if the platelet counts are on the lower side. So empirical therapy in the form of the prevention, we are giving the first prevention of the secondary bacterial infections. So first line antibiotic, we are giving the cephalosporin group, that is ceftriaxone and amikacin, and antimeningitic dose only. Then piperacillin and tazobactam, and sometimes in few patients we also give the meropenem also. Next please. Yeah, so this was all about the patient's management regarding prevention. As Dr. Parag and Dr. Neha rightly told that we know that the sandfly is considered to be a vector for this viral encephalitis cases. So, and one important observation of mine is that the sandfly completes it's a cycle in the human itself, like pro-mastigote form and amastigote form of this sandfly, they multiply in the human gut. So what my observation or what I feel that because of this multiplication in the human gut, most of the children, they are coming with the diarrhea vomiting. And because of the diarrhea vomiting, they are coming with the dehydration. They are coming with, because of the dehydration, there are altered renal functions and dyselectrolytemia. And rather than the encephalitis, they are coming with an encephalopathy. So on the basis of the sandfly and its breeding and its, its completion in the cycle in the human, this is what my assumption is. So on the basis of this, I have started all the children who are coming with viral encephalitis cases. So first I'm giving liberal fluid, like I'm giving boluses. If they are responding to the boluses, I ask my residents to continue with the at least 20% extra fluid than the normal requirement. So we are giving more fluid, keeping in mind about the diarrhea and dehydration. So they are responded well, and they are responded their renal functions, like after initial fluid correction and after giving extra fluid, their renal functions start decreasing. I mean, they are coming back to the normal. So this is how, and regarding the sandfly prevention, already Dr. Parag and Dr. Neha told that they breeds in the holes and crevices in the walls. The dark areas of the trees, like tree holes, dark rooms, store rooms. And we need to screen like 50 yards of the breeding places of sandfly. Next slide, please. The sandfly can be controlled by spray of DDT and linden as found effective control for the sandfly. So within 50-yard area, I think the spray has to be done around the human dwelling cattle sheds. They are there. And 5% malathion also it is recommended. Removal of the vegetations within the 50 yards that Dr. Parag has rightly told, and keeping the air and the ventilation in the houses. Filling the cracks in the crevices. Yeah, next please. So regarding the environmental control, the garbage, whatever, I always tell that do not store any kitchen waste also. Yeah, keep the kitchen bins tight lids and close the container, it should be. And whatever sanitary precautions we can take, stopping open air defecation, especially in the village area, the rural area, we can recommend. Fly papers, they are also available, and this can be easily made by using oil on that, castor oil if it is not available, so the fly will stick on that. I think Dr. Parag will be able to tell us more about using the fly paper, whether it is actually helpful or not. Next slide, please. So before I conclude my presentation, I would definitely tell that health education is very important, not creating panic amongst the community. So proper education is must. Many a times they are saying, parents, they are coming with a complaint of that, is it infected? Like whether one child is having viral encephalitis, so it is infective to the other child like other. But no, it is like it is a vector-borne disease. So it is not infective from the one person to the another person, like other viruses like measles, mumps, rubella. They are spreading by the respiratory or the droplets. Whether this is not being because it is a vector-borne, so it is not generally transmitted from one to the another. So the health education is very important. Always a good nutrition, because the malnutrition is one of the comorbidity which can lead to all the complications, and definitely the immunization. So this is what I insist that we need to spread the awareness regarding this. Thank you so much.
Thank you, Dr. Rinki. That was excellent. I mean, this is what we look forward to, that you are at the battlefront, and we are all reading things in the newspaper, but we are not handling any patients of this CHPV. So it was good to know from you how you are managing all these cases. So now we have time for question answers. I mean, it's little intriguing that 60 years since its discovery, we still have a lot of questions which are unanswered. Because way back in 65, this was discovered, and as Dr. Neha had shown in one of the slides, so many outbreaks have occurred. So why is it that we are still not knowing fully well about this virus? Why this virus is not studied so well? Even we are doubting the vectors also, whether mosquitoes can also transmit this. So this question is open to all the panelists, and I also acknowledge presence of Dr. Raju Bakshi, who is a community medicine ex-professor. You can also comment, Dr. Bakshi. And then we have some questions from the participants. There was a question for Dr. Rinki from Dr. Ishan Seth and Kiran Shah about age and gender distribution of your cases. And there was one question from Dr. Kiran Shah about Favipiravir, use of that antiviral agent. So Rinki, you can answer these two questions first, and
of
then
course.
we open up the discussion.
Sir, what my observation is that there is no gender differences. Male, female, they are equally affected in my, I mean, there is no gender differences. And age group, I have observed that, from the 6 months to almost 10 years. So in most of the 33 patients, they are ranging from this age group. And from the district, I would tell that they are coming from Mahisagar, Panchmahal, Godhra, and Chota Udeipur. So this and Vadodara district is Vadodara rural, I would say, and from one positive case which came from the Savli. After that, that rapid response team has visited the Savli area and they have done the screening and that spray and all. So after that, we are not receiving cases from Savli. And regarding the positivity of the cases, I talked with Dr. Apurva. He's the microbiologist at Gujarat Biotechnological Research Center. It is at the Gandhinagar. So he told me that it is false negative rate is also common in CHPV. So he said that it can be because of the virus mutation itself, which can lead to the false positivity, I mean, false negativity of the test. So I told that all the patients who are having the similar presentation, why only these patients, they came positive and why others are not coming positive. So his explanation regarding this was that it is possible in Chandipura because they are testing only CHPV, they are not testing other viruses. So they told that, yes, Chandipura false negativity rate is very high. And as Dr. Neha rightly pointed that it has a 5 antigen on the surfaces, among which the P antigen and M antigen, which is a very lethal. So this is very worrisome. I think in the future, we need to, do more study on the virus etiology itself and how can we further prevent its spreading.
Thank you. Dr. Neha, can you answer this
Yes.
question regarding Favipiravir, I mean, use of this antiviral agent?
There is no strong evidence suggesting that it will work. So there was initially it was in a matter that whether to use it, and but there is as of now we don't have any strong evidence suggesting that. So it is not considered as a part of treatment as of now, sir.
And any answer to my first question, Dr. Parag, you can tell us as to why we are lagging behind in investigating this particular virus after 60 years of its discovery. Dr. Parag, you can unmute. Yes.
So that's an interesting question, which is still unanswered for me. The sporadic nature of the disease probably I would feel is one such reason why it's not so common. So like everything in public domain, our memories tend to fade, and we have so much competing priorities that we tend not to give too much attention to diseases which are not so common. That's what comes to my mind, sir. Bakshi sir is here. I would wish to know.
Dr. Bakshi, your expert comments of wisdom.
It's Chandipura and not Rift Valley. The first answer.
Please repeat
because-
it. Your VT answer may not be, understood.
No, I'll explain. I'll explain. Because it is our circumscribed problem of a developing country struggling to get into the virological research. We have not been able to give adequate priority to it. Although it belongs to rabies category of virus, because the severity is not perceived and because it has been only small seasonal outbreaks, maybe we have not followed it up properly with the kind of research that it needs. But it's on way. The diagnosis and vaccine both are on way.
Right.
Sir, I just want to add on that. So as Bakshi sir correctly said, this sporadic cases, whenever that outbreak occurs, we have very limited cases, and in that on the field also, the team who are working on the field, they should have also a coordination. There should be one team, not many teams, who will go to the parents and the relatives, and they will ask the blood samples, and then they will try to research. So coordination at the field level. And whenever that outbreak occurs, there is the plethora for the research and more data. So whenever the team is going and asking, they will forget questions. Some question they will forget. So systemic review, whenever this outbreak occurs, we need that systemic work on that. So we get a good research data on that. That is what I feel, sir.
As a clinician, I have a question regarding diagnostics. So earlier we used to read that samples were being sent to NIV Pune. Now Rinki is talking about GBRC. So what is the difference in the turnaround time of the test that we do? And what is the difference between the tests that they do?
Sir, earlier we were sending to the NIV only since last year. So NIV took like 7 to 10 days for
So
getting.
what is the test that they do and what is GBRC doing? What is the difference? I understand both are doing RT-PCR. I mean molecular diagnosis only, right?
Yes, sir. Sir, in NIV, they are doing, apart from the CHPV, they are testing other viruses like herpes. So they are testing JE also. And because of this, their reports, they are getting delayed. Whereas, so in the video conferences with the health minister, that suggested that why in Gujarat, if the number of the cases are increasing in the Gujarat, why we are sending to the NIV if it takes so much time. Whereas now we have observed that the GBRC, that is Gujarat Biotechnological Research Center, they are giving us report within 1 or 2 days, maximum 2 days. So they are testing only CHPV as of now. They are not testing, but what is my suggestion, and what is their planning, that they are going to test other viruses if possible. So just only on the basis of the getting earlier report, we are sending to the GBRC.
Sir, in NIV Pune, they do RT-PCR and along with that neutralizing antibodies, IgM and IgG, that also
Virology also they are
from
doing.
serum and CSF.
So when does the IgM comes positive? After how many?
So sir, as I showed you the data, so 0 to 4 days. So we have seen in previous outbreaks, like day 4, we see IgM positive and IgG that will come later after 5, 6, 7, and after that also.
Right. And the question to Dr. Geeti Maheshwari, if you are, Dr. Geeti, if you are around.
Yes,
Dr.
sir.
Geeti is a microbiologist with Dr. Topani Laboratory, and she has been our speaker so often in Saturday Club. So Geeti, can you tell us about why it is not available in private sector, or is it available?
So there is availability of the kit because the only thing you require is the kit, because PCR facilities most labs have by now. The kit is available, but there is probably a hesitancy on the government's part to let us do it.
Okay.
So till the time they're clear about the fact that private laboratories can test, it's just a matter of acquiring the kit and doing it. So we do have a tropical fever panel, which covers most of the other viruses like dengue, chikungunya. It has malaria. It has there's rickettsia and salmonella in a multiplex panel for fever. And of course, we have all the other PCRs also widely available now. So there's dengue, chikungunya, scrub typhus, whole lot of other febrile illness panels for PCRs. But Chandipura, there is hesitancy to acquire the kit because the government may or may not let us do it. So that is the clarity which we require. I hope nobody is actually kind of asked whether we can do it or not.
Okay.
I've heard of one laboratory offering this, but I'm not sure of the authenticity, so I can't really comment on that.
Thank you for that information. And what is that? This multiplex PCR panel, the sample is CSF or talking about serum?
No, we are doing it from serum. We are doing it from. That is widely available, sir. I think Surat area there's a lot of demand for this febrile illness panel.
Hmm.
And there's just a small comment that in the future, there's also going to be, like, up till now, there's a very large multiplex panel which you can do from a blood culture positive bottle. But in the future, it's coming directly from blood. So that is going to be a huge improvement. So anybody who has, there's going to be a target of at least 15, 16 various pathogens directly from blood. But that is in the future. So it's not yet in the market, probably by the end of this year. So
Wow.
that's the update on the febrile illness multiplex PCR.
Thank you. Thank you. And for those who are not pediatricians in the audience, we are often mentioning AES. AES, acute encephalitis syndrome, where the patient presents with fever and altered sensorium. Just for the knowledge of non-pediatricians in the group. And Dr. Rinki talked about a lot of therapies that they are using, like antibiotics, antivirals, and that's the norm in AES, where polytherapy is norm because the situation is life-threatening. Just to clarify as to why Rinki is using so many medicines and still we are losing the patients. So any other question or comment?
Sir, I just want to ask about the fact as to why so many tests were negative in the PCR. So Dr. Rinki showed us that out of the total, I think only 11 were positive and the
No,
others were all negative.
Sure,
And then
positive. Yeah, Dr. Maheshwari, actually, I asked the same question to Dr.
Yeah.
Apurva at the GBRC, that why all these cases are coming negative. So he told me that, madam, there are so many other factors, like from sending the samples to the lab, their temperature maintenance, and their mutation, virus mutation itself can, change the gene. And he told me that the false negativity rate is very high in Chandipura. So though the presentation of the children are same, all the children are having the same presentation, altered consciousness, fever, vomiting, and they are of sudden onset 1 or 2 days only. And bleeding tendencies is also, but still their reports, and they are from the same area, like from the Panchmark, but still their reports are coming negative. So even I doubt that why they are coming negative. So I asked the same question to him, but he told me that, ma'am, this could be the possibility.
Okay, so because we don't really know about the mutation, so I hope that, like, for they set up for COVID-19 the genome sequencing facility, hopefully they will have enough data for the gene sequencing at a later date, maybe not really right now. But for a PCR to come so much negative is also very worrying. Like, it's a very, very sensitive test. So if you control the collection transport, then I mean, nobody knows, because nobody's done this in the private area where collection, transport, pre-processing are all better controlled, I would say. That's just a comment. I don't really know this. But I hope that so many being negative is very worrying in a PCR test. Right?
Yeah. On the contrary, I understand that PCR would take up any DNA of the virus, even if it is dead. So transport should not
Right.
make so much difference, I believe, if I am correct. Because we often see more false positive with RT-PCR because of the dead, virus DNA detection. Am I right, Dr. Geeti?
Right, sir. It does pick up dead, but since we don't know what the stability of the virus is, like RNA viruses are very unstable. So they don't become dead, like they kind of disintegrate. So if you don't have the genome well enough, it's not going to be picked up. So it's not about, for DNAs and for bacterial, it's a different thing, because in that you can pick up, like for TB, we do a lot of TB testing. So in TB, it's pick up dead TB. But
Right.
for viruses, the RNA viruses are very unstable. So they disintegrate rather than they die. So if they disintegrate, then you don't have any genomic material to pick up. So that's the challenge with RNA viruses.
So transport would be very important. Yes.
Yeah, that's why it's very, very important, and you must maintain the cold chain. So they actually, for COVID-19, we were sending samples to GBRC for a long time. We still are, for the genome sequencing facilities, and we had to, it's a real challenge to send it, because you need to send it in at -20, and that's dry ice, and dry ice is difficult to acquire, difficult to send. It's very difficult to handle. So -20 is a challenge. So, Dr. Rinki, you are sending samples at which temperature?
Ma'am, we don't monitor the temperature, but we are sending the sample in the ice packs and ice box only.
Okay, so there's no requirement for -20?
Oh, that we don't have
Because-
such guidelines for sending the samples. The temperature regarding the temperature maintenance and
Achha.
so we are
Okay.
sending in the thermal box with the ice packs.
Right. So ice pack is actually 2 to 8 degrees, but usually temperatures are around, like
That is
14,
what
15.
that is what my question is, where we are lacking in identifying the positivity cases when they are coming with the similar presentation.
I think
So
that
this is what I discussed with the microbiologist. Please tell us something that we can further improve where we are lagging. So as you correctly point out that -20, so how can we achieve the -20? That is what my next question is.
she told us
ma'am.
not using dry ice.
Dry.
Right. And also another thing is, that's my question to the experts, that this causes mainly an encephalitis syndrome. So it doesn't cause a meningitis. So is there a difference? Like you can't get a brain biopsy or anything. But then is it possible that maybe the CSF doesn't have the virus? Because for a PCR, you require the virus to be present, unless that's not there, it won't be picked up in the PCR. So is it a possibility that the CSF doesn't contain the virus because of the fact that there is mainly an encephalitis in this? That's the question I have. I mean, if somebody can help me out with that.
Ma'am, the ideal specimen for this encephalitis syndrome is the brain and then the CSF. So these are two. So there, the viruses will be there in CSF, but as you are saying, that we don't have that diagnostics that sensitive and as you are saying, the temperature liability and everything. But the virus will be there in the brain and CSF. That is for sure, as per the pathogenesis. But it is still, there are many unanswered queries. The evolving neuropathogenesis in this Chandipura virus.
Right. Okay. So thank you for that. So you mean to say that it would probably be the CSF, but maybe since we really don't know what is the sensitivity also, number one, of the PCR, and secondly, what is the complete pathogenesis? So that may be some factors in that. Right. So thank you.
So friends, in spite of the fact that many questions are unanswered, today we have learned a lot of things. I mean, it will help us, for pediatrician like me who is not handling CHPV, but handling patients and parents who are worried about this, we can educate them better with today's knowledge that we have gathered from all the experts. So thank you all the panelists for very brilliant presentations and sharing of knowledge. Thank you other participants like Dr. Bakshi and Dr. Geeti, and especially Dr. Kiran Shah for suggesting to have this topic in our club. So thank you all.
So the conclusion is that still it is a neglected virus.
Yes, sort of, because it comes intermittent.
In spite of 60 years of journey. Yes.
Yes. But I think this, because of the media, I think it has got enough publicity to make people do more research on this virus, I think. So with that, we end the session here. Thank you all for joining. Next Saturday, we'll have Dr. Rajiv talking to us about oncology subject. So thank you all. We meet next Saturday.